Good morning. On behalf of the Provider Relations team at the University of Iowa Hospitals and Clinics, we thank you for attending today's presentation, Chronic Total Occlusion of Coronary Arteries, Patient Selection and Current Strategies for Percutaneous Intervention with Dr. Sidkpal Panaich. He's a cardiologist here at the university. Our faculty's goal is to share information you can use about the latest therapies and techniques in medicine and answer your questions about how to partner with us in the care of your patients. If you'd like more information or to talk with him following this presentation, please reach out to your provider relations liaison or directly to him. These are informational presentations to enhance your clinical practices and to provide you with the most updated information we have. No CME credit is provided at this time. This program is being recorded and will be posted to our educational resources for referring physicians webpage. And at this time, I'll turn it over to him so he can start the presentation.
Thank you, Randy. Good morning, everyone. It's my pleasure to talk on this topic of chronic total occlusion, and we'll talk about our literature, the patient selection, and our current strategies for percutaneous intervention, and take you through what we're doing here at the U. So the objectives for my talk today would be to, one, evaluate the literature or the outcomes data for the CTO PCI. Then we'll understand the different PCI techniques and what we're doing here again at the U. And also just briefly finish off with some of the PCI complications that can happen during the CTOs and to recognize them. So, to begin with the definition of chronic total occlusions, these are basically 100% occlusions with TIMI zero flow of at least a 3-month duration to make them chronic. Now, these are very common, actually, and a lot of interventional cardiologists would know that at least 20 to 30% of the patients who are referred for coronary angiography will have a CTO of 1 or more vessels. What is the usual management strategy for these patients? A lot of them are managed on medications, anti-anginals, and then we can talk about revascularization strategies, which could be either bypass or PCI, and we'll focus on the CTO PCI for this topic, for this talk. Why not revascularize all CTOs? And by that I mean, why not do just PCI in all the CTOs and open them up? The reason for that is multifold. One, these are lengthy procedures, they're complex. Because of that, there is elevated radiation exposure and increased contrast during the procedure. The procedural success rate is lower, much lower than a normal PCI. There is therefore a higher risk of complication, and outcome data is somewhat limited. And when I talk about outcome data, there are only about 3 randomized trials that looked at CTO versus medical management in these patients. And none of these 3 trials actually reached their endpoint and did not show any difference between medical management as CTO PCI. The problem for all these trials is that you would see is, one, all of these had very small sample sizes. And the reason for that is all these trials took a very, very long time to enroll. The first trial, as you would see, has only 304 patients. The Explore trial took over 7 years to enroll. Same thing for the other 2 trials, and were actually halted prematurely. The Decision CTO trial was supposed to enroll close to 1,200 to 1,400 patients, but because of very, very slow enrollment, had to stop prematurely at 834, and therefore did not reach their endpoints. Moreover, most of these had surrogate endpoints. Then they did not actually enroll patients who had were very symptomatic. There was not a big viability testing to see whether the CTO PCI was performed in a viable territory. They did not, some of these trials did not actually, some of the Explore trial actually ended up doing non-CTO PCIs after CTO, therefore diluting your data. So, a lot of these 3 trials were limited by a lot of limitations, and unfortunately we are limited to observational data at this point because, again, these are complex procedures and it's very difficult to enroll patients in randomized prospective trials. However, we do have very good large sample registries till this point. One of the first registries, again by Dr. Miran et al., was published in 2011 that included over 1,000 patients looking at long-term outcomes. And at 5 years, patients who underwent successful revascularization, again, successful being the important term in these, is when you were successful at opening up the CTOs, you had a successful advantage in terms of both all-cause mortality as well as cardiac death. So patients who underwent successful CTO PCI had much lower, significantly lower all-cause mortality as was cardiac death in this registry, in this prospectively enrolling registry of over 1,000 patients at 5 years. And then, we get questions on what about the presence of collaterals. A lot of times, my colleagues would say, well, this CTO has got very good collaterals from the other arteries, so this should be good. Well, there's a big registry that looked at these specific patients and patients who underwent chronic total occlusion PCIs in the presence of collateral circulation. And again, patients who actually underwent revascularization had a significantly survival advantage as well as decline in major adverse cardiovascular events all the way up to 5 years. And then, most of the data, a lot of data revolves around the present, the improvement in symptoms in these patients. Again, looking at a large sample size of patients in the open CTO registry, and you would notice, patients who underwent successful PCI in the blue bars had much significant improvement in their angina scores as represented by different metrics, as opposed to patients who were unsuccessful in getting their CTOs revascularized. And the same patients, when you were able to successfully revascularize their CTOs, these patients had their anti-angiogenic medications de-escalated in a large proportion of patients. And when you looked at those patients who had the de-escalation, there was no significant difference in terms of their angina, dyspnea, or any other adverse events down the line. So you could successfully de-escalate their medications. And you would all know, prescribing medicines to your patients, yes, you can prescribe a lot of anti-anginal medications, but they have their side effects. A lot of patients are not able to tolerate multiple medications to control their pain. And so at one point, you have to decide whether giving them tons of medications is worth the side effects as well as, testing patients' tolerance. And so this provides some data that, yes, you can successfully de-escalate patients' medications and still have a very good symptom control once you achieve successful revascularization in these patients. And then there's another topic of patients who present with MI and have a CTO in a non-infarct related artery. So this, again, a large registry of patients. They looked at a long-term follow-up in these patients, and patients who presented with an MI, specifically ST segment elevation MI or STEMI, and had a non-infarct related CTO. So, and compared to those patients who did not have one. So if you would see that there was a significant survival advantage in patients who did not have a CTO. So if you look at the bottom curve, the bottom curve actually represents the red curve, the patients who presented with STEMI and did not have a CTO in their other arteries. Patients who had a CTO actually had a much higher incidence of adverse events of mortality as well as MACE. And even after ruling out those within 30 days, there was a significant survival advantage in patients who did not have a CTO. So if your patient has a CTO and lo and behold presents with an MI or STEMI, then their survival is significantly lower. So it kind of pays to not have a CTO, if you will, in your artery. Now, switching gears to arrhythmias. A lot of these patients, we know with ischemic heart disease will have ventricular arrhythmias. In another registry with over 1,400 patients, patients who had a CTO, the mortality in patients presenting with ventricular arrhythmias was much higher, 46% as opposed to 27% in patients that did not have a CTO. Now, why is that the case? There's this small study of only 3 patients, but they actually looked at the fact, once you actually do a successful CTO PCI, you're able to substantially reduce the low voltage area of scar and overall scar area in patients who undergo successful CTO PCI. And therefore, you could possibly reduce the burden of ventricular arrhythmias in these patients. Again, these are all observational data as I first touched upon. Now, again, switching gears, why is it important to have experience in these PCIs? So looking at these NCDR, and most of my colleagues and physicians would know that, our PCI gets recorded into our NCDR CAT PCI registry nationally. And looking at, over 70,000 cases, you would notice that as your experience in doing this procedure increases, there's substantial improvement in every parameter or metric, an improvement in procedural success, an improvement in getting your, having mortality benefit, and reducing your complication rates, reducing your fluoroscopy times, your contrast volumes. And so every metric actually improves as your experience in CTO PCIs increases. Why is that? Because there's, all these procedures involve skills in not just one technique, but multiple techniques. And that includes antegrade wire escalation. Then it goes over to antegrade dissection reentry, which is ADR. Then retrograde wire escalation and retrograde dissection reentry. And so when we actually look at these patients, there are multiple scores that have been, created across the world to actually grade these patients when they present to you. And as you add these different variables, the complexity increases. So the older the patient is, if they've had prior bypass surgery, if the attempt at CTO PCI has failed previously with you or with another operator, if your proximal cap at the level of the CTO is ambiguous or blunt, if you have a tortuosity in the vessel that has the CTO, if you have a lot of calcification, if the length of the CTO is long, and depending on the target vessel, for a progress CTO uses the FACT, which is our American CTO score. Left circumflex is thought to be pretty difficult. And depending on the collateral quality, if your collaterals are good, then you have a retrograde crossing option. So that actually reduces your level of score. And if you've had other things like what's your operator experience, if you've got obese individuals, it makes it more difficult. So different variables would increase. Basically, old patients with a lot of calcifications, long CTOs, with blunt caps, lack of good collaterals or retrograde options would increase the complexity of these procedures. So it's important to actually look at these cases up front to see which ones are worth the risk for the patient and have a good success rate. So this is a very good flow chart that most of the CTO operators use, and I take this from Dr. Berlakis's review article. So the first most important thing when we actually do CTO PCIs is to get angiography using dual catheters, which means that if you have an LED, you get a left main or a left shot, but you also have a right shot to get to evaluate for collaterals from the right coronary artery to the left. So the first thing that you actually look at is, as I said, if the proximal cap of the CTO, is it ambiguous, is it blunt, or is it actually tapered? You look at the distal target. So if beyond the CTO, is a vessel good? Is it very thready or diffusely diseased? Do you have an interventional collateral? So if the answer to all of that is no, if you have a nice tab with good distal target, then you might want to go antegrade first. The antegrade, usually we try to start off with antegrade wire escalations. If you don't have antegrade wire escalation, then we switch over to dissection reentry. And I'll show examples of all of these. If all of this is not meeting, so if you do not know exactly what the proximal cap looks like, if it's very ambiguous, if interventional collaterals are good, and you've got a very long CTO, then we might want to try retrograde. Again, retrograde, we first try wire escalation, and if that fails, then we try dissection reentry from the retrograde fashion. Starting off with antegrade wire escalation, if you're starting a CTO program, the first thing that you got to invest is in a lot of specialty wires. Again, I say that lot, but you have to have lot, but again, specific wires that you actually develop comfort level with. So I've highlighted the ones that we use here at the U, besides the Samurai RC, which is our workhorse wire. I tend to use soft taper tip wires for antegrade wire escalation, which are either the Fielder family or the Fighter family of wires. Then I tend to use medium non-tapered wire, which is the Pilot 200. That's my choice of wire. For antegrade wire escalation for controlled torque, I use the Gaia and the Judo family. And then you need to know when to use very hard hydrophilic tapered wires like the Confianza or the Hornet or the Estado. So those are the three wires out of the ones that I've highlighted that I use personally at the university. And those, again, are kind of last resort, and you need to know where they're going because they're very hard, high gram tip load wires that can actually penetrate and perforate the vessel if you don't know your direction where you need to be pointing them. So I show an example of this case. So you would see that this is your CTO right here, and to an inexperienced or even an experienced eye, you could see that the CTO length is not very long. And you would think that it probably would cross pretty easily, but let me tell you about this patient is that this patient has had this for over 10 years. And you can imagine this is a very fibrotic, dense, very rigid lesion. So this is a lesion that my colleague was trying for over an hour, and his wire, as you would notice here, keeps on going into the septal. So this lesion is so tough that would keep directing into a septal. So what we did, so he called, eventually referred the case to me. And what I did was I basically ended up putting the wire in the septal to mark the septal, and then exactly knowing where I was going to point. This is an Estado wire. Now, Estado wire, to some of those who've used it, is actually a peripheral wire and is a very specialty coronary wire that we use very, very rarely because it's a 20-gram tip load wire. And again, all of those who use coronary wires, my interventional colleagues, would know that most of our workhorse wires are in the range of either 1-gram tip load or less most of the times. And this, if you would notice, is a 20-gram tip load wire. So it's a very, very hard wire. It can perforate any direction if you don't know exactly where you're going. But again, I was able to, knowing where I had to poke, was able to do, again, not going too far into the vessel to, prevent injuring the vessel, then switching out for a workhorse wire, and we were finally able to stent all the way down and get the vessel revascularized. So knowing your wires is very important. Getting comfort level with your wires is very important. So get a comfort level with your wires and know exactly which one to use in which case. Now switching over to ADR, antegrade dissection reentry. So, when do we use that? One, if there is an ambiguous or impenetrable proximal cap. So ambiguous, you don't know exactly where are you headed down. So you don't want to poke and try to integrate wire escalation because again, if you don't know where you're headed, you can actually go out the vessel and cause a perforation. Second is impenetrable. If there's a lot of calcium, so if you've got a boulder in front of you, you go around the boulder. So you subintimally dissect and then re-enter back into the vessel. And for reversing the CTO segment, again, if you don't know what the direction of your vessel is, especially sometimes in the right coronary arteries where they're tortuous, ADR kind of provides you a nice way to follow the direction of the coronary vessel without actually perforating the vessel. Problems with it is unlike retrograde, you do not have control of the distal vessel. So you have to be able to kind of re-enter the distal vessel, and you need to know how to do that. So if your re-entry zone is calcified, the vessel is small, or you end up creating a hematoma, these could be problems for antegrade dissection re-entry. These are the two that we use most often. There are cases that we do not use these, but these things have made our life much easier for using the ADR technique. The first is a CrossBoss on your left that helps us create very controlled subintimal planes without creating very large ones. The Stingray is a reentry tool that has a wire port at the end and then has two offset ports on either side. And so this is a case that again has a LAD CTO extending from here to this point.
Go.
So showing an example of an ADR technique. So this is a left anterior descending coronary artery with a long CTO extending between this to this point, and you see the distal vessel. We tried the antegrade dissection. We tried the antegrade wire escalation, but the wire ended up going subintimal. So we switched over to the ADR technique. And this, as the arrow points, is your CrossBoss. We stop the CrossBoss once we have crossed the CTO segment, and then we switch over to the Stingray. And you would notice, again, pointed by the arrow, we switched over to the Stingray wire, and which crossed into the true plane. You always inject retrograde to make sure that you are actually within the true plane, and then we switched over to a workhorse wire, and then switched over and then started stenting, resulting up with this final result with stents extending between and the CTO segment. Again, this is another example on the right coronary side. As you would notice, very, very long CTO segment. It's anyone's guess, 50, 60 millimeters with, and kind of not non-ambiguous gap, but very, very long. Again, after the CrossBoss, we get the Stingray balloon out, crossover. This is your Stingray wire, exchange out for your typical workhorse wire. Again, every time you use a strategy, you want to finish stenting on a workhorse wire, because these wires, if you would imagine, if they can cross a CTO segment, they can also perforate. So you want to keep these as less as possible once they have done your job. And this was our final result for the CTO of the right coronary artery using both antegrade dissection reentry. This is a different case of antegrade dissection reentry where we did not use a CrossBoss. You would notice that this patient had very complex disease. There are collaterals going to the right. So the patient had a chronic total occlusion of the right coronary arteries, got some distal left main disease, diffuse LAD disease, and a CTO of the left circumflex coronary artery with bad osteo left circumflex disease. So very, very complex multivessel coronary artery disease. We ended up first rotablating and dealing with the left anterior descending coronary artery. And once we had revascularized stents all the way back up to the ostium, stented all the ostium, then we used what we call a star technique. That was the oldest antegrade dissection reentry, where you tried to push the wire. Again, we had to use that technique because of the osteal calcified left circumflex disease and distal left main disease, which would not allow us to use a CrossBoss without losing access. So we ended up using a star technique where we pushed the wire down and let it re-enter distally, making sure that our loop at all point of times remains small, and then aggressively balloon dilating all the lesions. Finally, we stented the distal left main, stented all of this, and you can notice, as opposed to the first picture you saw, that we were able to completely recreate his left system. This is your right RAL caudal view, the LAO caudal view. Basically, we were able to completely recreate again his left system. Now, again, going back to the point, why is it important to have every single technique? And we know that as you learn these techniques and go from the first, which all operators will start off with knowing antegrade wire escalation, knowing your wires, then learning the dissection reentry, and then eventually getting to the retrograde techniques is very important to actually help your patients and not having to stop at a certain point, because your lesion complexity and your success rates actually improve as your knowledge of all the techniques improves. This study from the Sound Medical Center that evaluated over 1,600 patients actually showed that the proportion of your successful PCI increases as you adopted the retrograde techniques. Again, we don't end up using retrograde techniques all the time because of the improvement of techniques, integrate wire escalation, as well as dissection reentry techniques. But it's very important to have that in your armamentarium to actually get those final patients. And I'll show you this case. This is, again, you would notice that very similar to the case that I just showed, that we achieved success using integrated dissection reentry. This is a different patient, again, with a very, very long CTO segment. Again, we started off with integrated wire escalation, but you would notice as with where the arrows point, that distally we were never ever able to get into the true lumen using multiple methods. So we were always subintimal. And if we tried dissection reentry at this point, we would end up losing one of the two branches. And at most times, obviously, you want to maintain every single branch if we could. So we switched over to our retrograde technique. You see a wire that is coming over from the left LAD through the septal collateral and comes back into the PDA. The patient had a lot of dense fibrotic, long CTO. So we had to basically make sure that we dilated. So, this is using both your integrate as well as retrograde techniques. We had this wire that we left in the subintimal space distally that we ballooned and basically did a dissection re-entry from the retrograde, or a reverse card technique where we basically ballooned the subintimal space and then we're able to re-enter and create an external loop going from the left all the way externalized to the right catheter. So now we have a complete working loop. We start working from the integrate site now, it's putting in balloons and stents from the integrate. We know since we came true to true that we are now distally true. Our vessel is maintained true distally, so we can start ballooning and stenting from the proximal. So this was our final result. We were able to kind of stent and get the whole right coronary artery preserved without losing any branch that, as I said, we would have lost if we tried to do a dissection reentry in this case without actually switching over to retrograde techniques. Finally, I'll just talk about some complications. The complication rates in CTO PCI, again, is higher than your normal PCI, but again, to just give you a flavor, they're not the crazy high. They're not like double digits, triple digit numbers. So if the most feared complication is perforation, so the rate of perforation is about 0.3 to 0.4% in normal PCIs, and it's definitely higher. It's about 2 to 5% depending on which registry you look at. But again, it's not 10, 20, 30%. So it's, yes, higher percentages than your regular PCIs. But when we talk to our patients, it's important to kind of tell them on what they're looking at and what they should be expecting. So again, this goes through a whole list of PCI-related complications. What could happen? Again, extra cardiac. Obviously, we get dual access. A lot of times we have to go femoral because we need larger bore access for these patients. So the rate of vascular complications is somewhat higher. Again, we talked about the fact that these are longer procedures with more radiation. So we have to be very cautious of our fluoro techniques in these patients. We do end up using more contrast. So at some point, a lot of times what we've done is actually stop midway. It does not hurt to actually bring the patient back if your procedure is getting very prolonged, to both reduce your risk of radiation injury as well as reduce your contrast load. A lot of times what we do is investment procedures where we balloon and then we bring them back for actually finishing up the procedure. Cardiac complications, the most feared ones again are perforations that can lead to cardiac tamponade. And it's important to realize that, as opposed to what we believed previously, that patients with bypass, since they don't really have a functional pericardium, we thought that they would not have a cardiac tamponade. What we've realized is that these patients can actually have localized tamponades, despite the fact that they don't have a functional pericardium. And even though they will not have a classical tamponade, they can have localized tamponade and would at times need either a CT-guided drainage or surgical drainage. So it's important to be still cautious in patients who've had bypass. Would lead to aortic dissections, either because of aggressive catheter manipulations or sometimes in osteal lesions. If we're doing ADR or retrograde dissection reentry techniques, that dissection can extend all the way up to the into the aorta. Periprocedural MI, the rate is a little bit higher, again, because of the complexities of the procedure. We have to be careful of maintaining very high ACT or clotting times in these patients, get them very nicely anticoagulated, because it can lead to clot formation in these patients when we're using dissection reentry techniques. When we're using retrograde techniques, it can actually lead to problems, dissection, or occlusions or thrombosis in the donor vessels or the collaterals themselves. Can lead to embolization, because we're exchanging a lot of products, wires, microcatheters, stingrays, CrossBosses, and so on and so forth. So it's very important to keep your systems well flushed. Can lead to spasm of the donor vessels. So all of these things have to be taken into account. You know, people have actually reported loss of stents or entrapment of your material when going through these very calcified, chronically occluded vessels. So that's another thing they need to look at. Perforation, as I again, told that looking at different cases, there's a 2 to 5% chance of having coronary perforation. Half of them actually in this registry required an intervention. Tamponade happens in less than what would you expect, and only about 20% of the patients. But it's important to recognize these and be able to manage these and call on your surgeon if you need it. So it's very important to have a surgical backup if you are going to try these chronic total occlusions. Very, very, very less number of patients will end up with surgery, but it's still good to have a surgical backup if needed, and to know how to manage these complications if they occur before you start a CTO PCI program. So, I finally will end with, when should we do it? Should we do it? So I think, the benefit of CTO PCIs is I would say, most importantly, limited symptoms. So I think when your patients start having angina despite multiple medications, and probably is the time to refer them for CTO PCI. There is, as I showed, there is some, there's actually a lot of observational data. Unfortunately, we don't have randomized data, but a lot of observational data that we might be able to reduce their outcomes. But again, there's no randomized data to prove that we actually can reduce their outcomes distally. But symptoms are very important, and I always refer to getting different ophthalmological surgeries, getting a knee replacement, getting a hip replacement. These are all symptom improvement, and so there's only a certain point till which your patients can tolerate chest pains, and so it might be important. And when you do that, then when you refer the patients to us or to a CTO PCI center, what we look at is what's the benefit and what's the risk involved to the patient. And that's where these CTO scores that I talked about come in. So we determine what's the success of these PCI going to be, and what's the rate of complications that's PCI going to be. And then when I talked about the different CTO scores, we actually tell the patient that, well, this is how your complex or lesion is. This is what your success rate is, 70, 80%, maybe 90% on how easy it is. And the more the success rate or the chance, or the less the complexity, the less the chance of complication, and vice versa. And then obviously we tell the patients that these are going to be complex lesions, so they don't fall into the same category as other patients. So they would need long-term dual antiplatelet therapy, because the risk of stent thrombosis and intervenosis in these complex lesions with complex stents, long stents, is somewhat higher than usual PCI. So they would have to be on dual antiplatelet therapy for somewhat longer. All right, I'll end with any questions that you might have.
There are a few questions. What are the top symptoms to consider with patients before referring to you?
So, I think the most important symptom is that's a little easier is angina, the typical anginal complaints. When your patients are having typical anginal complaints, which means that they're having chest discomfort. It could be a typical chest discomfort. It could be a jaw pain or any type of discomfort when they have with exertion, with physical or emotional stress, that gets relieved with rest, with relaxation. So those are the important things that people that again physicians would know when to recognize typical anginal complaints. Unfortunately, some of the patients, especially diabetics, older patients, and females, will not have typical anginal complaints. What they might have is shortness of breath when they walk, and so those are a little difficult to tease out. But once we've actually made sure that there's no other etiology for their shortness of breath, and some patients would just get fatigued, very fatigued because their cardiac output doesn't keep up, because their hearts don't keep up with their exertion, and those are more difficult, and especially when you get older, patients are not able to differentiate between getting old, having other comorbidities, and what's causing fatigue. So it gets a little more difficult. So I would say typical anginal complaints, yes. Once you have typical anginal complaints and you are on 2, 3, 4 different anti-anginal medications, you're not being controlled, or you are on different anti-anginal medications and you're having side effects and you're not able to tolerate them, and you're just pushing them for the sake of pushing it. So it might be time to actually consider CTO PCI in those patients.
Great, thank you. So it sounds like the duration and frequency of the angina is when it's appropriate to refer to you.
Yeah.
So that's the biggest consideration. Is there a certain amount of time we should follow our patients before referring to you then?
I would say it kind of depends on the level of comfort. I usually end up giving them, when I see patients who are kind of de novo patients who actually haven't seen any other referring, and somehow seeing me first, I usually try to up titrate their medications to whatever they would be able to tolerate. Some of them are able to tolerate 3, 4 different medications, and some of them are not able to tolerate more than 2. And I would probably reevaluate them on almost like a month to 2 month basis, preferably like a month basis. So I would come see the patient, go up on a few of their medications, put them on 2, start off, have them call me in a month, in a week, and see how they're responding. And if they're responding a little bit better, I'll go up on their medication over the phone in a week or so. But I would probably not give them more than a month or 2, because it can get very discomforting for the quality of life. And so I would say about 1 to 2 months is most where and then it kind of changes. Some of the patients are just having very bad symptoms, and they'll call in within a few weeks because they're not able to tolerate it. So it cuts short. Some people want to give it another try, so we'll give it a little over 2 months, but 1 to 2 months is what it is.
Great, thank you. I don't think there are any other questions. So thank you very much for presenting, and thank you everyone for attending today's presentation with Dr. Sidkpal Panaich. If you would like more information or to discuss any patients or procedures with him, please reach out directly to him or to your provider relations manager, and we can connect you. So again, thank you everybody for attending, and have a great day.
Thank you, Randy. Thank you, Seth. Have a good day, everyone. Thank you. Bye-bye.